All right. Thank you, everyone, for joining us today. I believe we have a record turnout here, which is amazing. I think that tells you a little bit of the importance of the topic and the prowess of our presenter, perhaps. So he's not going to look at me and smile. There we go. You are at the Bray lecture. Hopefully you're in the right place. All of this started several years ago, and Tammy Bray is here with us. Hi, Tammy. She started this whole thing, and this is about sharing knowledge with our communities, and not just at OSU, but around our communities. A lot of people are online right now, as an example. So with that, I wanted to start a little bit with how I met Robin. And I received an invitation to go have lunch with the senior vice president of Moda Health and up in Portland. I said, sure. And so up I went and took my daughter with me for other reasons. And so the four of us with Sean had a really beautiful lunch, and we began talking at a smaller level, and then it just grew into this big what's wrong with healthcare kind of moment. Not what's wrong, what are the challenges in healthcare? And Robin, I was pretty fascinated with his ability to think globally about healthcare, and in a very humble way. So Moda Health is one of the few health companies, I will say, that is doing fine right now. Most of our hospitals and healthcare systems are really under significant fiscal strain, and Moda Health seemed to be doing well. And rather than take credit for that, Robin chalked it up to luck in some educated guesses when they had to take a direction. And he'll tell you a little bit about that today. And so between the humble nature of Robin, learning as soon as I walked into his office and saw all the Native American decorations around, that he is a proud Cherokee member of the tribe. He'll share a little bit of that with you today too. All of that is near and dear to my heart. So with that, I formed a fast, I wouldn't even call it, it's a professional relationship, but Robin and I are actually good friends at this point. He and I and Izzy went to dinner last night, my daughter, and just had another lovely time. So we'll continue to do that into the future. So with that, when the topic of this lecture came up, I thought, well, what a ripe opportunity to share that whole healthcare system knowledge with the rest of our intellectual community here in the College of Health and at OSU. So with that, I'm going to read the little bio blurb, but that's all the fun stuff that I just said. And then we'll invite Robin up. Robin Richardson is the Senior Vice President at Moda Health, driving enterprise-wide innovation, Medicaid strategy, change is coming there, and value-based care transformation. He oversees key initiatives that position Moda at the forefront of integrated healthcare delivery, including leadership of the coordinated care organizations and strategic partnerships with major state accounts. With a career spanning executive leadership in national healthcare associations and pharmacy organizations, which is his home school here, Robin brings deep expertise in shaping policy and advancing healthcare models across commercial and government markets. He chairs the board of the EOCCO, that's the Eastern Oregon Coordinated Care Organization, and serves as secretary of the OHU IDS board, while holding directorships with Modality DX, CellTex, and the Oregon Business Council. And Moda, just so everyone knows, is doing a whole lot of very new, cutting-edge research and treatment things that are really fascinating. So I think you'll get a firsthand shot of that today. He contributes to the infrastructure and health policy through his role on the Interstate Bridge Replacement Program's Community Advisory Group and as a member of the American Diabetes Association. And Robin, are you currently president?
I'm Secretary-Treasurer last year, and I'm on the board.
Okay, Secretary-Treasurer and the board. Exactly what it says in front of me, but I thought you were president at some point.
2016.
All right, 2016, there we go. His governance experience includes leading Oregon's high-risk insurance pool, serving on boards for the Oregon Business Association and OBI, and presiding over the Oregon State University College of Pharmacy Advisory Council. He's a former two-term chair of the Foundation for Medical Excellence, recognized as an alumni fellow of Oregon State University and honored as an icon of pharmacy. And I see Dave over there, the Dean of Pharmacy. Robin is also, as I mentioned, a citizen of the Cherokee Nation. And with that, please welcome Robin Richardson.
Well, good afternoon. Can you hear me? Adequate? Okay, great. Thank you. Thank you, Debbie, for that generous introduction. And congratulations to the College of Health and its 100th year anniversary. That's amazing. And I would believe from our conversations that you're the perfect person to lead the college into the next century because your vision is exactly what's needed. You get it. You get what's going on, and we need that. And I'm going to talk about that a bit as we go through this. So, in addition to that biography, I thought I would introduce myself in a more personal way to you. So, in addition to that biography, I am the great grandson of the Robin. My parents didn't know that when they named me. I'm the great-grandson of Adam Corntassel, whose photo is up there, the gentleman in the white hair. I am the great-grandson of Johnson Corntassel and the grandson of Robert Corntassel. And as Debbie said, I'm a member of the Cherokee Nation. I'm a father to three sons, Brian, Grant, and Sam, father-in-law to Molly, Mari, and Ollie, grandfather to Liam, Riley, Nora, and Malcolm. I'm also a devoted dog dad. You see my two dogs up there, Tucker and Ziggy, and also husband to my wife, Janine. In addition to those who know me, you will know and follow me on LinkedIn, you'll know that I'm a caretaker of a very large garden. And there's pictures of that garden. It was developed in 1939. And it's a very special place, but even more special this time of year. And those blooms, all those pictures are from this year. And as noted professionally, I'm Senior Vice President at Moda, and I'm in my 27th year at Moda. I'm used to making presentations to boards and management teams, but not a lecture like this. This is very daunting, to say the least, but it's great to be Tammy Bray's the lecture at honoring Tammy. It's wonderful, and I'll talk about our relationship in a little bit. But I don't want to lecture to you. I want to talk to you. And I don't want to lecture you even talk by sharing a lot of facts and figures. I want to share real experiences, and I want to inspire you at the end. So let's see if I can do that, and we'll get started. So, the healthcare system is in chaos, transformation, and crisis. And the answer to the first question, which is the title of this, is the healthcare system in crisis, chaos, or transformation, and what are the opportunities? The answer is yes, yes, yes. If you go back, to put this into context, do you know what the total spend of healthcare was in 2024 in the United States? $5.3 trillion. That is not insignificant. So that gives you a scale of the scope of the issue that we're talking about. We have a financial challenge, but it's not a single source. It's a variety of sources. It's utilization, Medicaid funding, as we would know, Medicare funding. There's the slide behind me shows, which I need to use the clicker. Where is that clicker? Which shows that Medicaid or Medicare has already reduced reimbursement to providers and facilities, and they're talking about another 30% reimbursement. I mean, if you're listening to anything of healthcare in the news, health plans are fleeing Medicare Advantage. They're running as fast as they can because of those cuts. At some point, there's got to be a resetting, but it's significant, and the losses are astounding and staggering. But in addition to Medicare, it's an increase in chronic disease incidence, pharmaceutical costs, specialty drugs, GLP-1s that everybody hears about, expensive new technology, gene therapy. All of those things are contributing to the financial burden that we're bearing. But we also have a workforce issue. Sorry. There we go. We also have a workforce issue. A lot of healthcare professionals are aging and retiring or just leaving the profession for a variety of reasons, burnout being one. So on the left side of the screen, it's healthcare workers who are 40 and over, and it tells you where we're headed. And on the right side is healthcare workers and nurses who are planning to leave their jobs in 2 years. That's a considerable challenge, but I'm going to talk about that. The federal government is also reducing the amount of money that professional students can borrow. And they didn't categorize nurses as a profession. That's unbelievable, absolutely unbelievable. But those challenges create both financial and access issues. And on the left-hand side of the slide, it talks about individuals who live in areas where health professionals are not really accessible. And on the right-hand side is a poll that was recently done in the Oregonian about how hard it is to get an appointment with a primary care or a specialist. 50% basically of the poll said, it's difficult for me to get an appointment. For me, it takes me 6 to 8 weeks to get an appointment with my primary care provider. But I'm also lucky I have one. That is a challenge right now. Rural health. There's also a significant problem with rural health as well. It's around the state and the country. Rural hospitals are closing. Services such as birthing centers are closing. In our geography, the hospital in Baker City closed its birthing center. So if you live in Baker City, you cannot have children now. You have to go to LeGrand or Ontario. And for those of you that know that geography in the winter, that is not an easy drive, one way or the other. That's the death of a small town. We're working very diligently and hard to reopen that birthing center. And I'm fairly confident we're going to be able to do that. In the most recent Oregon legislative session, though, the legislature took a highly unusual step and provided money to prevent a rural hospital on the coast from closing. Now, to counter this, there are rural health transformation funds that you may have read about, and I'm going to talk about those in a bit. We also have a disconnected system. Providers, payers, medical records, data, costs, and patients. Even though providers say things like electronic medical records are connected, in reality, everything is disconnected. In Eastern Oregon, we thought that providers in small towns knew each other and talked to each other. Well, we found out that was not true. If I take the medical records as the example, they're probably the most connected item in the healthcare system. But even they are disconnected. In my case, I get my care from a large health system, and I routinely have my doctors ask me what happened at the last doctor visit. I said, well, it's in the medical record. And they routinely say, I didn't have time to read it, I couldn't find it, I couldn't see it, or it was too difficult to access. And if it was a provider in another healthcare system that used the same electronic medical record, it's even worse. That is a problem. One of the most serious disconnects, though, is with public health. And I'm going to talk about that in a little bit. You're going to see I use quotes. My boss, Robert Godey, is here today, the CEO of Moda. And Robert has a lot of quotes that I like and are very pertinent for a lot of these conversations. Things are never as bad as they seem, and things are never as good as they seem. And the reason that quote is pertinent for today's discussion, we've been here before. This is not new. We've been here before, and I'll talk about that. There have been other times of challenges like these, and solutions were developed to address them. I wouldn't say that anything that was developed solved the problem, but they've temporarily addressed them, and they laid the foundation for future solutions. Do you remember the managed care days of HMOs, ACOs, PPOs, and ACOs? Did these address the solutions of their time? Yes, to a degree. But none of them completely solved the problem of the future. They laid the foundation, though, for future solutions. Remember Medicaid in Oregon in 2012. Governor Kitzhaber was facing a massive budget deficit. They were going to cut provider reimbursement by 40+%, and they were going to reduce the Medicaid eligible rolls significantly. The CCO concept emerged as a potential solution. Did the CCOs address the problem of that time? Yes. Were they perfect? No. Did they evolve over time? Yes. Are they the solution for today's problems? Yes and no, and I'll talk about that in a minute. Had anyone outside of Oregon developed a CCO before then? No. Or after then? No. So everyone was excited when Governor Kitzhaber went to Washington. But the reality of the solution, wasn't just that the CCO concept had to work. It was that the CCO concept in each region had to work, especially Eastern Oregon. When we were notified that we were selected as the CCO for 12 counties in rural Eastern Oregon, I was elated for about 5 minutes. I was on a drive home from Hermiston, and I was just ecstatic for 5 minutes. And then panic set in. And the reason panic set in, can we do this from a budget standpoint? We have cost-based hospitals. Can we really do this from an operational standpoint? We also have federally qualified healthcare systems, and the cost-based hospitals get 100% of their costs reimbursed to them. The governor didn't even know if the CCO concept was going to work, let alone he didn't think that any CCO concept was possible or would work in Eastern Oregon. For the same reasons, I panicked. And to complete things, the CCOs weren't just responsible for Medicaid medical. They were responsible for medical, dental, behavioral health, and non-emergent transportation. That was also significant. So how did the CCOs address the same major challenges of the problems I had just discussed at the beginning? From a financial perspective, global budgets. That was core to that. Provider capitation, value-based payments, frontier rates for pharmacies, quality metric payments, primary care medical home payments, behavioral health integration payments, and community health worker payments. Do you know that in Eastern Oregon, we pay primary care providers more for a Medicaid patient than insurers pay for those same providers for a commercial patient? More for a Medicaid patient than commercial payers pay. We even moved some of those concepts into our commercial book of business. Each year since 2016, can I get some water? I need a...
I think I took yours.
Did you take it?
Yeah, I took it.
Did you drink out of it?
I did not.
Every year since 2016, a Mercer report for the Public Employees Benefit Board named Moda as the most cost-effective health plan on a risk-adjusted basis over both Kaiser and Providence. Now, I wouldn't have believed that. I don't think you would have believed it either. It's all of these payment models that we put into place. They work, and they work not only in Medicaid, but in the commercial market. The workforce challenges. Well, we focused heavily on primary care. That's one of the mistakes right now in the healthcare system. Primary care isn't valued like it should be. We focused very heavily on that. We focused on provider partnerships. We have 4 hospital systems that are part owners in EOCCO. Community health workers, language interpreters, and health worker scholarships. We also needed government and state government and local government support, and we got that. There were times we had to ask, can we delay this from happening for a little bit? And the government said, fine. We also engaged the community, though, and community leaders, which is another key to this. When Debbie mentioned luck, these were some of the decisions that we had to make, and we didn't know what was going to work or not, but the decisions worked, and they were very important. So we developed local community advisory councils in each county. We didn't have to do that. We did in each county, and then we did a regional advisory council. So then we learned what's important to the county. You know, everybody thinks when they look at Eastern Oregon, oh, it's all alike. It's everything east of the Cascades, and they all act alike. And they're not alike. In one county, mental health may be the priority. In another county, dental may be the priority. So we learned what those priorities were. Now, so the EOCCO model, it was really the answer for rural health. But I'll talk about the healthcare transformation funds for a minute. Each state is currently eligible for $1 billion over 5 years for rural health initiatives. Now, we have several ideas of how to use that, one of which is to use the funds to train primary care providers in Eastern Oregon how to treat people with diabetes. We have a health equity issue in Eastern Oregon. There are no endocrinologists. If you want to see an endocrinologist, you've got to go to Boise, Seattle, Portland, maybe Spokane, but there's no endocrinologist. So primary care providers are treating people with diabetes, and they're not trained how to do that. They need to be trained to do that. And they also don't want to always treat people with diabetes just like mental health, and because they don't get paid for it. It takes longer to see people with mental health. It takes longer to see people with diabetes, and they don't get paid for it. So when we do that, we'll have to change the payment systems, and that's okay. They need to be paid for that. From a public health perspective, and when I talk about public health right now, I'm talking about just global health. We developed several food as medicine initiatives. Veggie RX was one of those. And it was not unusual for me to receive calls from county commissioners thanking us for increasing the amounts of fruits and vegetables in their grocery store, because this was about providing access to Medicaid recipients to fruits and vegetables. We put drug cabinets in pharmacy deserts like Fossil, Oregon, where there is no pharmacy. We developed drug addiction programs in jails. We developed a variety of programs and resources to address social determinants of health. Short-term housing is one of those. To address the disconnect, the first year as a CCO, we did not hit all of our quality metrics. It wasn't because the providers weren't providing good quality care. It's that those electronic medical records again, we couldn't pull the data off of those electronic medical records. So we found a company that overlaid the electronic medical records, pulled the quality data off of them, sent it to us in real time, and we in turn sent data back to Eastern Oregon providers in real time. Even the urban areas weren't doing that. That was amazing. As I said, we also established provider-payer relationships, and we fostered provider partnerships. Partnerships are the key to a lot of this. Our healthcare system is disconnected, and part of it is because of a lack of partnerships. Hospitals don't usually engage external physicians, and external physicians don't usually engage hospitals. For innovation, we invested highly in primary care medical homes. When we first started, there was one primary care medical home in our entire Eastern Oregon geography. Now 95% of our patients are seen by a 3-star or higher primary care medical home. We even have a 5-star medical home in Enterprise, Oregon. And for those of you that may not know Enterprise, it's in the northeast corner, farthest corner you can get of the state. We have a 5-star medical home there. In regards to funding all these initiatives, how do we do it? Well, we did it from healthcare cost savings. All we received from the state was the amount of money for the eligibility category for Medicaid and some administrative revenue. In other words, we received the same amount of money that the state did prior to the CCOs. Under a global budget, the concept was if you saved money, you got to keep it and reinvest it in your communities and in your providers. That's exactly what we did. If you lose money, it comes out of your pocket. That's the risk part of that. That's the benefit of a global budget. I'm missing one slide here. In addition to, Robert has two other quotes that were supposed to be up here. Don't boil the ocean, and one step at a time. And you have to be careful about that because it can be overwhelming. And in addition to many of the things that I just talked about from EOCCO as being the opportunities for today, what are the opportunities for today? And how should we address them? Now, I will say one thing right off the bat. The one thing that we're missing in all of our healthcare systems is research, models, data, pilots, education, training, and certification. So when I talk about these categories, think of that as, so value-based payments, we don't have any research or data on it. We're just doing it. We know it works because it works. We don't have any data on a global budget. We don't have any data on our primary care medical homes of how they improve. And people ask me all the time, do you have data? No, we don't, but it works. We need those things. Those are opportunities that exist. So opportunities are global budgets, value-based payments, developing, identifying, and using inexpensive technology, paying primary care providers appropriately for their services. We need to think about how we make the healthcare system sustainable and affordable. It is not affordable today. Adding money to the system is a partial solution, but it is not the solution. We have to use and create things that save the system money. Now, one of my sayings is, there is enough money in the system, it just needs to be redistributed. Our ability to form and operate EOCCO is a testament and example to that statement. We were given no extra money. So all those things I talked about, we did without any extra money. They were all, there's enough money in the system, it just needs to be redistributed. From a workforce standpoint, we need to be thinking about new care models and training. Not just the workforce of today, but the workforce of tomorrow. New care models like hospital at home. True team-based care models where the team needs to be bigger than the few clinicians in the room or the clinic. The team also needs to include payers and others. We need to think of new future healthcare roles. Patient navigators in hospitals and clinics, not discharge planners. We spend so much time focusing on how to get the patient out of the hospital and not what to do after the patient is out of the hospital. That's what patient navigators would do. Digital health specialists, AI-augmented clinicians, population health managers in hospitals and clinics, not just insurance companies. We need to consider expanding the scope of practice for our current healthcare workforce. Pharmacists, nurses, public health, and community health workers. So now I'm going to talk about public health, and I'm hopefully going to get on the right slide. No. Public health is one of the most underutilized components of our healthcare system today. It exists in every county, in most communities. They and their services are mostly disconnected from the mainstream medical system and from payers for a variety of reasons, one of which is a lack of payment or reimbursement. They need to be paid for their services and work. They need to be utilized as providers and extenders. We need to find ways to utilize them and expand their scope of practice. We need to develop a payment system around and model for them, just like we did for community health workers. When we developed the community health worker program, we developed 3 new billing codes. We got them approved by the state and became the statewide model. We need to do the same thing for public health workers. Another significant opportunity is in mental health. We have 2 distinct and separate workforces. Do you know that there are providers who only see mental health patients who are Medicaid eligible, and we have providers who only see non-Medicaid individuals? Let's break down that barrier, and suddenly we'll have a much larger mental health workforce. There's no reason for it to exist. Are these expanded practice roles and new workforce models a lower quality of care? I would argue it's a higher and better quality of care. We want physicians and others to work at the top of their license. My cardiologist sits in front of his computer typing while I'm in his office. He doesn't look at me in the eye, he doesn't examine me, he's typing in his computer while I'm in his office. Do I really want my physician to spend that time writing up my visit, or instead have someone in the room taking notes about my visit, or even the computer listening to our visit and writing it up for him so that he could review it later, so he could see me and treat me as a patient. AI is at the top of everybody's list for healthcare, for everything. One of the things we need to do with AI is we need to reskill clinicians and executives, health executives, on AI. We need models to make AI operational and not experimental. We need to facilitate data-driven decisions. But at the same time, we need to focus on digital ethics. That's a real issue that we need to work on. AI and clinical decision-making, support, and diagnostics. We need AI to help with risk identification, stratification, and prediction. Who are the patients most at risk? Who should we be reaching out to focus on as a system, not just as a payer or clinic? That's what happens today. Either the payer does it or the clinic does it, but we don't do it as a system. We all need to be on the same page. AI can help with revenue cycle management, documentation, coding, scheduling, and other administrative functions. We need to be conveners and educators. Conveners of current and future providers, payers, tech companies, government, and communities. Is there a value or opportunity in convening a regional transformation consortium or a regional partnership consortium? As we learned in Eastern Oregon, the healthcare system doesn't meet or talk without someone bringing it together. What about a healthcare tech showcase or competition? I am on the American Diabetes Association National Board and have been for a long time. They have an innovation challenge at our scientific sessions, which are coming up in June. 5 finalists are selected to pitch their ideas to a panel of judges in front of a large audience. The winner receives a $50,000 investment, and they receive from ADA's Innovation Fund, plus an opportunity to work with business development firms and marketing firms. It's really a fun and exciting challenge. These are just some of the opportunities to address the current healthcare challenges. But all of this leads me to the right slide and to the real opportunity in times of crisis, chaos, and transformation. It's leadership. In 2012, think about this. When Governor Kitzhaber went to Washington facing that substantial budget deficit, you know how much money he was asking for? $2 billion. And he had a brand new idea that nobody else had tried before, the CCO model. In addition to the concept, as I mentioned before, needing to be successful, each of the regions had to be able to develop a successful CCO. And they had to produce the cost savings. He guaranteed cost savings to the Obama administration. This is an example of opportunity and leadership. So let's go back to my brief discussion about community health workers and EOCCO. Several years ago, we identified a significant workforce challenge in Eastern Oregon. We had a clear need for people who could serve as trusted healthcare extenders in clinics and a variety of care settings. Recruiting primary care providers was difficult and still is. We needed community health workers. This was a title and a role that really didn't exist 5 years ago. There are a few training programs in the Willamette Valley, but for our region, they simply didn't work. The cost was high, the travel was burdensome, and the time away from work was unacceptable. We had a problem, but no clear solution. Around that time, I had the good fortune of meeting and working with Dean Tammy Bray. We first met when we served together on a search committee for the dean of the College of where she was the search committee chair. During our visits, when she would come to Portland after that, she would always stop by my office. And during our visits, she would often say, I really want to find something that we can work together on. I said, I agree, but I didn't know what that something was, and especially with the College of Health. Then one day, just before one of those visits, I was presented with a problem with no solution. So during my visit with Tammy, I told her I had a problem with no solution. It was about community health workers. She listened, and then she said, "Let me take this. I'll think about it, and I'll get back to you one way or the other." So maybe a month or so later, she came to my office, and I was honestly expecting her not to have a solution. I was expecting to say, "I appreciate that, Robin, but there's nothing we can do." But she completely surprised me. She came back with a solution. She proposed that the College of Health would develop a community health worker curriculum, a certificate program. They would secure the Oregon Health Authority approval, and they would deliver the program using their agricultural extension offices, which they had in every county, and they were wanting to transform those, combined with online learning. I was struck by how creative and unexpected that idea was. I had never imagined that a college or university would be interested in developing and operating a certificate program. And I certainly hadn't expected a college or university to pursue this kind of business-focused partnership. And certainly not with an insurance company like Moda or EOCCO. Since the program's inception, we've trained 650 community health workers in Eastern Oregon. So they now have living wage jobs where they would had to move to do that. 650. Building on that success, we later identified a similar need for language interpreters. Once again, the College of Health stepped up, designing and implementing a language interpreter training program. And we have since trained almost 90 language interpreters in a very short period of time. In return, we paid the College of Health about $2 million. This is another example of opportunity and leadership. This is one of my favorite quotes from Winston Churchill, "Never waste a good crisis." And this is really about opportunity and leadership. As I've said several times today, we've been here before, and we're going to be here again. Each and every time we encounter moments like these, opportunities are everywhere. But there's one opportunity that stands above all others, and that was at the core of the examples I just shared from Governor Kitzhaber and Dean Tammy Bray. Every challenge we face requires leadership to move forward. Every opportunity requires leadership to turn possibility into reality. Without leadership, ideas remain ideas, problems remain problems, and change never takes place. Leadership is not easy. If it were, everyone would do it. Leadership demands courage when outcomes are uncertain. It asks us to step forward when there are no guarantees of success. Leadership can be unpopular. Leadership is not a singular act. Leaders have to lead people and organizations who may not see or share the same vision and may or may not want or be ready for change. Leaders need other leaders. And while leadership often looks smooth, easy, and confident in hindsight, in real time, it's uncomfortable and even frightening, just like this lecture is to me. It's easy to lead when everything is going well, but leaders are not defined in calm times. They are identified and forged in turbulent ones. Tough times not only reveal leaders, they also create and or continue to build them. Leaders are not anointed. They are made and evolve over time. They are made through experience, through risk, and through the willingness to raise a hand when others hesitate. Most leaders simply want to make a difference. Even the most accomplished leaders need time to grow into new and bigger roles. Every exceptional CEO I've ever known will tell you the same thing, that their first year or two is humbling. Leadership is learned by experience and by doing. My own career has been shaped by leadership, not because I sought it out, but because I stepped forward when something needed to be done. I didn't always know I was ready. I didn't always feel confident, but I was willing to try. Time and again, I raised my hand, not to be the leader, but because a problem needed a solution or an idea needed to be tried or moved forward. That willingness led me from early leadership roles as a student to founding and leading organizations, serving on national boards, and driving innovation today. None of those opportunities were handed to me. I wasn't chosen because I was fearless or flawless. I was chosen simply because I stepped forward. And every time I was scared, I was worried about failing, about not being selected, about being exposed, about not having the right experience or background. But here's what I learned. In every one of those moments, others had the same opportunity. Many were just as capable. The difference wasn't ability, it was decision. While I moved forward, others waited. Some doubted themselves, some let fear, timing, or uncertainty decide for them. Not because they couldn't lead, but because they consciously or unconsciously chose not to step forward. Opportunities don't just happen, they wait for leadership. They need leadership. I've been fortunate to learn from some very remarkable leaders, like Tammy Bray, Robert Godey, and Governor Kitzhaber, people who embody courage, clarity, conviction, and vision. Here's what I've also learned to be true. Every person in this room or listening online has the capacity to lead. And the question I'm sure you and I get regularly, how do you become a leader? How do you know when you're ready to lead? Well, leadership doesn't require a lofty title. Not everyone's going to be a CEO, a president, or a dean. And that's not the point. Leadership shows up in professions, in workplaces, in teams, in communities, families, and moments when someone needs to say, I'll take this on. When things go wrong, what do people always say? We need leadership. So how do you know when you're ready to lead? It starts with a moment of clarity. When you look at a situation and think, this could be better. I think I could do this differently, or I think I know what needs to be changed. Whether your idea is the right idea or not, it doesn't matter. It's the fact that you see it, that you care enough to imagine something better is the signal. That's readiness. That's leadership calling. The question isn't whether leadership is needed. The question is, who will step forward? Who are the next generation of healthcare leaders in Oregon? How will we identify them? How will they be supported to learn, grow, and develop their own vision for the future? Oregon is uniquely positioned to answer these questions. We've been fortunate as we are home to some of the brightest minds in healthcare. Leaders with deep experience across policy, delivery, operations, research, and innovation. Their collective knowledge, insight, and vision represents an invaluable resource. But you know what? We're not taking full advantage of that. We're not leveraging that. So I mentioned 3 leaders already. Who are the others? Bruce Goldberg, Jack Friedman, Tim Goldfarb, Brian Drucker, County Commissioners John Schaefer, James Williamson, Mike Bonetto, Representative Rob Noce, Ken Preventure, Chuck Hoffman, Dennis Burke, Jim Mattis, David Howerton, and Sri Nagala. These are just some of Oregon's extraordinary leaders that we're not using, we're not leveraging. I see the same leadership potential emerging all around us today in individuals who will shape what comes next. Here at OSU, it's obviously Dean Debbie Craig, Dean Dave Bearden, Ole Taratullo, Associate Dean of Research at the College of Pharmacy, Allison Myers, Associate Dean for Extension and Engagement at the College of Health. At Moda, it's Julia Ceballos on value-based payments, Sean Jessup, CEO of Medicaid and Medicare programs, Chandra Wargren and Carly Rodriguez on all things pharmacy. Outside of Moda and OSU, it's Jeremy Davis, CEO of Grand Ronde Hospital and the current chair of the Oregon Hospital Association Board. Liz Powers, Winding Water Clinic, a 5-star medical home. She's a physician. Becky Hultberg, CEO of the Oregon Hospital Association. Art Matheson, CEO of Good Shepherd Hospital in Hermiston. Do you know in Hermiston, every one of their surgeons are trained in robotics? Every one of their surgeons. It's amazing. In Hermiston. I'll give you an example of Ole Taratullo. Ole and I had lunch about 2 summers ago, and he was talking about his role at the College of Pharmacy in the research area. And he was telling me what the issues were and what he thought the challenges were. And there was a position that was opening, a leadership position that was opening. And I asked Ole, I said, are you going to apply for that? Oh, no. I'm not a leader. I can't be a leader. I don't know what to do. I don't know how to do it. So I challenged him. No, you need to think about that. And I challenged him again. You need to think about that. And when we ended lunch, I said, you need to think about that. You really need to, I think you'd be perfect for it. It was some months later in the fall, I think I was here for a football game, and Ole came running up to me, gave me this big bear hug. He said, you changed my life. and he took the leadership position. And his group was just featured on OPB and in the Oregon Stater for the work they're doing on cancer. All because of his leadership. I didn't change his life. I nudged him. I challenged him. I pushed him. That's what leaders need sometimes, just a little nudge or a little push. The future of healthcare in our state depends on shared responsibility, shared leadership, shared vision, and a shared commitment to learning from those who have led and developing those who will lead next. This challenge is bigger than Moda and bigger than the College of Health. So, I'm going to get a drink of, there we go. One of the things, I'm going to get a drink of water here in just a second. One of the things I haven't talked about yet is what's Moda's role in leading healthcare into the future. This is another time where I also step forward. This is a quote from Robert that I love. The healthcare industry is too focused on the end and not on the beginning. That couldn't be more of a true statement. Moda is expanding its focus on the beginning. But this is not necessarily new. Years ago, we started a dental benefit that provided extra cleanings for pregnant women and people with diabetes. We know that bacteria in the mouth can cause premature births, and it makes diabetes very difficult to manage. For diabetes, it was new, but it was not at the beginning of the disease. For pregnancy, it was new, and at the beginning of life. We were the first health plan in the country to do this, but now it's not new anymore. We want to get involved earlier in healthcare. You know what's allowing us to do that today? Technology. Technology beyond, but including AI. Recently, Moda acquired a controlling interest in a local rapid diagnostics company called Modality DX, which Debbie mentioned. Rapid, 10-minute or less results, inexpensive, non-invasive saliva or finger prick, early and definitive tests for conditions and diseases difficult to diagnose like preeclampsia, type 1 and type 2 diabetes, rheumatoid arthritis, lupus, and multiple sclerosis. But as we peeled back the layers of the company, we discovered much more than rapid tests. We discovered that at the core of these tests were patented disease signatures and technology providing the ability to quantify a treatment's impact on those signatures. It's a little show and tell. This little box with a simple saliva test or a simple finger prick, blood drops from a single finger prick, will quantifiably tell you if you have a particular disease, sometimes even before you have symptoms, what your level of that disease is, and whether or not a treatment actually works, pharmaceutical or other, and to what degree it is effective for each of those diseases. Again, the results are quantifiable, highly accurate, rapid, non-invasive, and inexpensive. We also have the ability to identify disease signatures, not single markers for disease signatures, which is more accurate in disease detection than a single marker. Towards the end of last year, we had a conversation with our chief science officer about identifying new disease signatures. His first disease signature took 3 to 5 years to develop. You know how long it took him to develop the 3 new disease signatures? 3 months because of AI. We have more disease signatures in the pipeline, and this technology is and has the ability to be transformative. Stem cells. When I say those words, people cringe or they are excited. My cardiologist cringes. My primary care provider is excited. For those that cringe, stem cells conjure memories that were once banned in the U.S. as a result of their sources. For those that are excited, they offer new technology, new tools, and new hopes for treating disease and or promoting longevity. Today in the U.S., you can get stem cells pretty much in any major metropolitan area in every state and from multiple and different providers. From chiropractors in Beaverton, yes, from chiropractors in Beaverton, to orthopedic surgeons in Portland and Seattle and Spokane. Does this mean stem cells are all good? No. It depends on their source. on how they were developed and grown and a variety of other factors. And yes, the FDA has not approved stem cell use in the U.S. yet, even though in some orthopedic surgeries you might be given the choice to get them during surgery, as some doctors are using them during knee and hip replacements to speed recovery. We've taken a controlling interest in two different stem cell companies, one in Houston and one in Mexico City. The stem cells in Houston are for a very small amount of fat tissue, and the stem cells in Mexico City are from dental pulp from shed baby teeth. I've had my own fat extracted, although in my personal opinion it wasn't enough. And I have had my stem cells grown and administered from it. But I have witnessed stem cell miracles. One example is a young woman with lupus whose father is a physician. The young woman had and still has lupus, but it was so bad she was dying. In 2022, she spent more days in the hospital than out. She was dying. She was confined to a wheelchair as she couldn't walk. She was starting to pray that she would die. Out of desperation and desire to help, we suggested stem cells. She received a simple infusion of her own stem cells from extracted fat. 2 months had elapsed, and she was not improving and was still getting closer to death. Since March of 2023, so this is only about 3 months from the end of 2022 to 2023, she's not spent one day in the hospital. She is no longer confined to a wheelchair. She is walking, driving, dating, and going back to school, and I just saw a graduation picture of her. She was on 23 different medicines for lupus. She is not on any lupus medicines today. Her doctors at a large California university-based medical center can't explain it. She's not cured. In fact, she recently took the lupus test and tested positive. But the stem cell treatment caused her disease to go into remission. It's literally unbelievable. I'm not saying that every lupus patient or every other patient will have the same results for this or any disease. There's really no hard scientific data for stem cells and stem cell treatment, but there's lots of anecdotal evidence and information. It's believed that the stem cells that come from the dental pulp in baby teeth have more neurologic properties because of how they're developed in the womb. And they use them in Mexico City for stroke patients and other types of things like that. I've seen, again, remarkable results. But with our reader technology from the Rapid Diagnostic Company right there, we can quantifiably show if a treatment, stem cell or pharmaceutical, affects the lupus disease signature and by how much. That's transformation. I just hosted a science summit of the scientists from the 3 companies that I just mentioned, and we're now working on a proof of concept with an ultimate goal of getting FDA approval of stem cells by themselves or in combination with a pharmaceutical for lupus and eventually for other diseases. This is the beginning of a lot of work to do, and there are a lot of ifs. But if this could change diagnosis, treatments, outcomes, and lives. We've also just opened a functional medicine clinic in the Johns Landing area of Portland. Functional medicine, acupuncture, nutrition counseling, infusions for wellness, other things. Functional medicine, blood tests to detect things that you won't have run by your physician. No other insurance company in the U.S. is doing anything like this. Everyone is still focused on the end. We want to get to the beginning of the disease. We want to improve people's lives. The main goal is not saving money. That's an outcome. The main goal is to keep people healthy and improve their lives. Really, an insurance company thinking about doing and wanting to do things like this? Pigs must be flying. But this is how we're leading. And this comes with all of the things I said about leadership before. No guarantees, no certain outcomes, uncomfortable, even scary for me and for the companies. But what could be better than making a difference in people's lives? Right now, I'm having one of the best times in my career. Maybe we can or can't change the world, but we can step forward. We can lead change to make a difference in our portion of it. We need to strive for perpetual and continuous improvement of our healthcare system and its leaders. I hope that you and I, individually and collectively, will do just that. This is not an ask. It's a choice, a decision to lead, to step forward, and that decision belongs to each of us. In closing, I'd like to thank Dean Craig, Tammy Bray, Robert Godey, and Oregon State for allowing me this special opportunity. I'd also like to thank Katie Pollan, Moda's Chief Marketing Officer, for her help with my slides and being a sounding board when I needed to be calm in preparing for this. And I'd like to thank each of you who are here today in person or online for your time and attention. I hope I did accomplish my initially stated goal. I want to inform you, educate you, and inspire you. Thank you.
Robin, oh, there we go. Very informative and definitely inspiring. So we have a reception outside. Do we have a Robin's gift here? Why don't you come back up, Robin? We got a little gift for you. It's a gift pack from Oregon State, plus there's a plaque in there that commemorates your talk. So,
thank you so much.
And I'll look for it in your office next
Appreciate
time I
it.
visit.
It will be at my office.
All right. Thank you, everyone. Please, I don't know why I have to lean in like this. It drives my daughter crazy. Please join us for a reception right now. Thank you.